Perfect. Okay. So first of all, who am I? I suppose this just tells you that I'm an eternal nerd more than anything else. I hold a physio degree from Manchester Metropolitan University, and I have a master's in women's health and continence from Curtin University in Perth in Australia. And I've done some postgraduate work in paediatric continence and continence promotion, perinatal mental health. I have my own pelvic health clinic here in the west of Ireland, and I do some lecturing for undergrads. I'm a mentor for the new grads. I teach quite a bit, and I'm also an educator for the Maple device in Ireland with Niall from Genomed. So I'm busy. I've got 2 kids as well, which keep me on my toes. But I have to say I'm very lucky in that the work that I do is not really work. I love my job. So it's not everybody that can say that. So that's a real bonus for me. So I do have to acknowledge some wonderful ladies as well in terms of where the components of my presentation have come from, the knowledge that I've gained. So Taryn Hallam, Judith, Irina, and the other Judith are lecturers from my master's in Australia, and they have just been the ones who have created such a foundation for pelvic health the world over. They're incredible educators, and a lot of the research that's done in Australia is done by these ladies. And then, of course, Gillian McCabe has been really instrumental in helping me get to grips with the maple, using it in my clinic here. She's based in Cardiff in Wales, and then my go-to for lots of like really difficult questions is of course Meryl in Holland. So we got to do some training with her, and it was absolutely phenomenal to see how her mind works with the maple. So I have to credit all these wonderful ladies. So what is stress urinary incontinence? Well, according to IUGA and the ICS in 2022, their terminology says that it is a complaint of involuntary loss of urine on effort or physical exertion, or on sneezing or coughing. Very long-winded way to basically say it's the leakage of urine when you do not want it to happen, and it's usually on exertion. Some stats that I think we should look at though, just to get a real kind of idea of how this problem affects women, especially the world over, and it's really prevalent, is that 1 in 3 women will experience stress incontinence at some point in their life. Although the risk increases with age, approximately 50% of teenage girls report stress incontinence when playing high impact sport. And that's huge. Like if they're already leaking urine and they're nowhere near childbearing age, that's going to have a knock-on effect for them in pregnancy and postpartum, perimenopause, postmenopause. So for me, I really tend to try to work as much as I can with sports teams and educate trainers on, you know, the need for acknowledgement and awareness and open conversation about this with young girls. As the mum of a young girl myself, I'm really you know, conscious of it. And I also need to kind of try and get the word out a bit better that one of the biggest reasons for young girls to drop out of sport is incontinence. They won't say that at the time. They'll just say, oh, you know, I don't want to do it anymore. But when we query them in anonymous questionnaires, that is one of the biggest reasons that they drop out of sport, and that's very sad. Just a little aside, the other 2 reasons are painful periods and breast size, and these are all things that we can manage, and it's very sad to see girls dropping out of sport. Perinatal SUI then, 70% of women will have a small leak in the 3rd trimester, 50% will get better post-baby, but if the leakage started before pregnancy or earlier in pregnancy, they will likely need to see a women's health physio postpartum to really get to grips with their pelvic floor training. 1 in 3 will leak after having a baby, and the evidence shows that doing pelvic floor squeezes in pregnancy can help with postnatal leakage. Again, that's a really key point that we need to get across to our ladies if we're seeing them in pregnancy. A lot of them feel like, oh, sure, look, I'm carrying a baby, I've got the weight of everything in my body at the moment. There's no point in doing pelvic floor squeezes right now. I'll just deal with it afterwards. But we do know it is important to encourage them to do it in pregnancy and not just wait for the problem to get worse. Then postmenopausally, approximately 50% of women postmenopause will experience stress incontinence, with the rates getting significantly higher after the age of 60. Now, we know so much goes on in that time period. We have the drop in progesterone, the drop in estrogen, and all of that then contributes to sarcopenia setting in, osteoporosis setting in. Women are less active, they are more conscious of incontinence or prolapse and things that then reduce their ability to exercise comfortably. So it becomes a vicious cycle. So the more that we can get their stress incontinence under control, the more that we can keep their body fit and strong and healthy, because women are living longer and longer and longer these days. So we don't want them to be in a really bad way, say from the age of 60, but that person could potentially live till they're 100 in a very bad quality of life. So really addressing stress incontinence can be a game changer for everyone at all ages. But why does it even matter if you're leaking? Because all of these celebrities tell you it's absolutely fine to just put a pad on it. We have a Charlie's Angel, not a Charlie's Angel, a Victoria's Secret Angel. We have a really boss girl mom in Kris Jenner. We have Katy Perry. We have Whoopi Goldberg. We have comedians. We have a really A-list superstar Oscar winner in Samuel L. Jackson. They have all done adverts with Tena, Always, all these continence pads saying, you know what, it's fine, just put a pad on and get on with your life and everything will be wonderful. But really, it's not good enough to just say that. Because let's look at the real impact. So if we look at the impact first on social well-being, we know that social isolation is huge. And I really noticed this here in Ireland when COVID was at its highest, because all the public toilets around where I live certainly were closed down. And a lot of people used to go for their walk and they knew where the toilet was, so they were okay to go and they had their little stop-off points. But when the toilets were closed, they just were isolated to their house because they were afraid of leakage away on their way around their walk. And we know that individuals with stress incontinence often experience feelings of rejection and social isolation due to the fear of leakage episodes in a public setting. The amount of people that tell me they turn down lovely invitations to weddings and lovely events because they just don't want to be caught out, and they're conscious of wearing black and not having to carry a big handbag where they have a change of clothes and pads and things like that. I noticed that especially as well for men. It's kind of an aside, but men who have had their prostate out and they leak urine, in female toilets, we have the ability to get rid of a pad in a bin in our toilets, but that is not in most male toilets. And that's a real kind of bone of contention for them in relation to getting back to their normal activities. There's also workplace challenges. So up to 23% of women with urinary incontinence will take time off work. And that is a significant impact on your professional life. We don't want this to be the thing that is stopping you from getting the promotion or being the thing that is progressing you on your career ladder. When we also look at the impact on physical well-being, we know that there's activity limitations. So stress incontinence can lead to a reduction in physical activities, like I've already said, as individuals may avoid exercise or other movements that could trigger leakage. Postpartum women as well, approximately 85% of new mothers will experience postpartum incontinence. And that can hinder their ability to engage in regular physical activities like getting back out, doing a mother and baby class, potentially getting back to the sports that they were doing, whether they were a runner or they played football or basketball. So that's not good. We know that particularly for mothers' mental health, physical activity is very important. And then looking at mental well-being, anxiety and depression is key. Women with stress incontinence are unfortunately more likely to experience anxiety and depression. And from a sexual health perspective as well, the research shows that up to 43% of individuals with urinary incontinence feel that their condition adversely affects their sexual relations with their partner. And that leads to decreased desire and satisfaction, poor self-image, poor self-worth. And all of this seems like sure, look, you're leaking a little bit of urine, big deal, get on with it. But when we look at the wider impact on so many aspects of life, relationships, families, it is huge. So there's a number of contributors to stress incontinence. We have pregnancy and childbirth, which is the one that most people would kind of focus on. But that's not always the case. Where we have the clinic here, we actually have a number of nuns that come into us, and obviously they've never been pregnant or had children, but they're coming in because of stress incontinence. Menopause, we've already covered, I suppose, a little bit about that decrease in estrogen and progesterone and how we lose the muscle bulk and the strength in our body and our muscles when we get older. If there's been a nerve injury to the pelvis or the lower back, that can impact on how the pelvic floor works. If the person has an increased BMI, if they've had a previous pelvic surgery in that area, if they have a chronic cough, which I currently have at the moment, and my God, I know my pelvic floor is taking a toll because of it. If they have diabetes or a prolapse, so for instance, if their bladder is the problem with the prolapse and it's kind of tilted out of place, that bladder then isn't allowed to function properly and can contribute to leakage. If they have constipation, and that is a huge, huge problem that we really need to get under control from the very young all the way up through. We have a number of women that come in here postpartum and even older, and they say, you know, I'm constipated, but I've always been that way. So sure, you know, it's not a problem. Yes, it's a huge problem because constipation takes up space that the bladder should have for filling and emptying. And if the bladder is being squeezed externally, that throws off the signals that your bladder sends to your brain, and it can really impact on leakage. High impact activities, definitely we know that high level athletes, gymnasts, trampolinists, here in Ireland, Irish dancers especially. Oh my goodness, there's hailstones outside. I hope that's not throwing off the sound. It can really make a difference to the person's continence. Your genetic makeup. We know that particularly with prolapse especially, if your mum or your granny or your aunties have had prolapse, then you are genetically more likely to have it yourself. Likewise, if there's anything on the paternal line in terms of hernias, then that contributes to your risk for a prolapse as well. And we know that prolapse then is a risk for stress incontinence. Certain medications can be a problem. So for instance, people who are on a water tablet like furosemide, if they're just generating a lot of fluid and they're needing to go to the bathroom more often, if their bladder is super full and then they cough or sneeze and the mechanism for closure isn't good enough, they potentially can have stress incontinence. Their social environment, is it that they're able to get to the toilet quickly enough? Are there appropriate toilets? Are the toilets the right height? We know certainly school is a big factor for this. It's not every child or teenager that wants to go and use the toilet in school. There's a number of them that I see that will not go to the toilet in school because the cubicles are quite open and they don't want to have people hearing them or smelling anything. So social environment is a really big thing for these people. If they have urinary tract infections, then you do generally notice that you will have more SUI because of it. Their fluid intake and type. Here in Ireland anyways, I'm seeing people carrying bigger and bigger and bigger water bottles with them. And there's this perception that none of us are drinking enough water. And in actual fact, when we analyse what the person is drinking, it could be that they're having 3 litres of water, a smoothie, a protein shake, a cup of coffee, an energy drink. And when you calculate all that up in total, they're drinking maybe 5-6 litres of water, of fluid a day. And that's just excessive for our body and our bladder's capacity. Also the type, is it a bladder irritant? Is it that it is more caffeine related, alcohol related, food colouring, spicy food, that sort of stuff? Albeit that does tend to contribute more to urgency and urge urinary incontinence, we do know that there is a little bit of a link with the stress incontinence side of things as well. And then for the men, of course, the prostatectomies and the enlarged prostate can be a problem for the bladder too. So what is normal continence and how does it fail? So we look at 2 things. To maintain continence, we need, one, our intravesical pressure. So that's the pressure within the bladder. And the pressure that will push the urine out. We also look at urethral pressure, and that's the force acting on the urethral lumen to keep it closed. The true terminology is that urethral pressure is determined by the fluid pressure that would just open a closed urethra. If we want to put it quite simply, it's to be able to store urine. The pressure inside the bladder must be less than the force able to hold the urethra closed. So there's a real kind of Goldilocks situation here. It's hard to get it just right, and it's a very fine balance. And when we look at it in terms of stress incontinence, it's actually a multifactorial situation. So if we look first, I suppose, at urethral anatomy, when there's dysfunction in the urethral anatomy, this leads to intrinsic sphincter deficiency. And then when there's issues with the urethral support structures, this leads more to urethral hypermobility or urethral support deficiency. So 2 very different things can be one or the other, or a combination of both, and that then contributes to the mechanism of stress incontinence. It's certainly not as simple as a weak pelvic floor. When we look at the urethral anatomy, we look at the internal urethral sphincter, how the muscles work with that, the components of it. Is there plenty of estrogen? Is it nice and plump and full and pillowy? We look at the external urethral sphincter, and different muscles are in there. So we have concentric muscles, we have smooth muscles, we have the mucosa and the glands in the urethral wall. The more that they are plump and full and well vascularized and they are in kind of conjunction with each other, they create almost like a tension, which helps to keep the urethra closed when it's meant to be. If we look more on the other side of it, more the structural side of the urethral support structures, we need to look at the pelvic fascia and the pelvic floor muscles more for that side of things. So I'll explore them a little bit further. So we'll look at urethral hypermobility first. And the urethra has a real support system, and if that fails, then we're in bother. It has a range of structures that provide a supportive layer upon which it rests. So we have the urethra, then we have the anterior vagina, we have the pelvic fascia, and then we have the levator ani, or the pelvic floor muscles. And the interplay of each of these supports the urethra in its correct position. But if any one of them is damaged, then the support for the urethra is not there. It allows it to move lower and not sit in its usual position. So I don't know if you can see my arrow. I hope you can. If we look here, you can see you have your urethra, so that little circular area there, coming down from the bladder. We then have the anterior vagina in front of that. We have a circular ring of muscles going around, in that it's the pelvic floor, and we have a layer of muscles that go across the top of it as well. And the fascia lies in underneath as well. So there's a real series of structural supports there. If we look at the pelvic fascia in particular and the ligaments, we know that this is absolutely key for the structure and the support of everything. If your your fascia is damaged, then everything is allowed to just slide down a little bit. So we look at the endopelvic fascia. It's an enveloping connective tissue network for the pelvic viscera. It suspends the supports and fuses the pelvic organs to the arcus tendineus fascia pelvis, or the ATFP, and that itself inserts onto the pelvic side walls and the pubic bones. The major anterior component is the pubovesical ligaments, and they attach between the pubic symphysis, the bladder, and the anterior pelvic wall. So it's like this little net of support that keeps the bladder and the urethra suspended up in place. The pubocervical fascia forms the anterior vaginal wall and the posterior bladder support. So what we're looking at here is this white sheath that goes and lifts the bladder up, and it really helps to just suspend everything up in place, ideally. Now, when we go back to look at how this all contributes to continence, we go back to the hammock theory by John Delancey back in 1994. This was like a seminal piece of research, and it has been built on and built on and built on by further researchers as the time goes on, but his definition is actually really the most simple. So he said we need a good urethral position plus a urethral backstop. So we don't want the urethra to be kind of wobbling and coming down, and we need something to kind of put a bit of pressure on it, like a backstop. The way some people describe it is, if you imagine you had a hose on the ground and it's sitting on the ground and the water is flowing through it, if you stand on it, that becomes your urethral backstop and it stops the flow. But if that hose was lying on the ground and there was a hole underneath it, if you stood on the hole, you wouldn't create a backstop. You wouldn't stop the flow of water through the hose, because it just dips down and creates a bend, and there's no urethral backstop. And that's where the posterior urethra comes in. So the posterior urethra is supported by a semi-rigid sheet of fascia that creates a backdrop against which an increase in intra-abdominal pressure can be resisted. As the increased intra-abdominal pressure places force through the anterior urethra, the anterior wall is compressed onto the posterior wall, causing increased closure. So it just tightens everything over on itself. Damage to the posterior urethral supports allows funneling of the bladder neck, so it allows things to open more rather than closure during the intra-abdominal pressure. And when we talk about intra-abdominal pressure, this is the cough, the sneeze, the jump, the bounce, the loud shout at the children, or one of my patients this morning said he is noticing a lot of leakage when he is at a football match and he's shouting and he's getting excited. So he's doing fine on a normal day-to-day basis, but when there's that extra pressure, it catches him out. So let's see what this is. Hopefully this will play, and I'll play it a couple of times, but I'll just show you what I mean in terms of the diagram first. So we have our normal our abdominal cavity here, we have our bladder, and we have our urethra coming out, and then this is our pubic symphysis at the front. When the person then does a Valsalva or a cough or a sneeze, you can see that the bladder gets pushed down and it almost allows the urethra to funnel out. So it changes if we're looking at this bottom left-hand picture, part B. But then when the funneling occurs, it allows the urethra to open because it flattens that angle there. So this video shows it beautifully. Now, just to orientate yourself, it is more upside down. This is the bladder here. And I want you to focus on what happens on this part here where the urethra is. And I'll play it a couple of times because it does happen quite quickly. You can see this person coughing. So you can see the cough and just watch what happens here. We have our funneling and then you can see the urethra opening. So I'll just play it again. I'll just do it one more time because it is quick. You can see that opening. There we go. That's what I have a physio colleague in Dublin and she likes to call it your wobbly pipe. So if there is a wobble in the pipe, it doesn't have the same structural integrity to keep it in a good position. Okay, so let's move on. Oh, it's going again. Right, so that's the urethral hypermobility. So the urethra is allowed to move more than it should ideally be moving. Let's look at intrinsic sphincter deficiency now. So this is the other part of it. So basically, this is a lot more simple, I suppose, in that the sphincter isn't closing well and the bladder neck is left open. Elements of this include the volume and structure of the urethral musculature, the pudendal nerve innervation and the external urethral sphincter facilitation, autonomic innervation and the internal urethral sphincter facilitation, vascular closure of the urethra, the urethral wall structure, and elasticity. So there's a whole lot of elements here that in an ideal world should be working absolutely perfectly. But if you, for instance, have a patient who is now well down the track postmenopausal, perhaps they had an early hysterectomy and their ovaries and fallopian tubes were taken away, so their estrogen levels decreased very rapidly from a young age, they don't have the same plumpness and structure and volume in their sphincter anymore, so it doesn't close as well. So you can see that it can be slightly open or it can be quite well open. There's also the people, say, who potentially had a very long, prolonged, drawn-out delivery where the baby's head was right down in the pelvis. There was a lot of pressure put and strain and stretch put on the pudendal nerve. So now the innervation to the sphincter postpartum and down the track has diminished and it's not giving the same sensation. So the closure isn't as good. Is it vascular? Is it as time goes on? Is it, you know, is there a medical condition going on? Is it the diabetes? Is it MS? Is it something neurological? All of these things, simply put, really just as we generally age, contribute to more intrinsic sphincter deficiency becoming a bigger issue. If you're just kind of on paper trying to decide what your patient may potentially be, intrinsic sphincter deficiency is when the people feel like they are just leaking a little bit all the time, continually dribbling out. And that's because genuinely the bladder neck is open, so the bladder is not closed. It's allowing that continual little bit of a leak all the way down. If it's more urethral hypermobility, it's more when the person is put under pressure. As you could see from the video, it was the cough or the sneeze that allowed the urethra to be hypermobile, to funnel down and then to open up. So those people generally notice it's more of a spurt, but they're okay when things aren't too bad, when there isn't excessive intra-abdominal pressure on them. So it's those people who maybe at football, when they run and then they catch the ball and they stop and turn direction really quickly, they'd notice a spurt. So just when we're listening and kind of getting a clinical picture in our head, these are little things that are just good to have kind of in the filing cabinet. Okie dokie, let's go to the next one. So if we look at the urethra a little bit more, because I, like, as part of my first degree, I did a whole year of human anatomy dissection. And truth be told, the pelvic part of it was minimal, like we really didn't look at it. But even the urethra itself is such a complex piece of equipment. It is, it extends from the bladder neck to the external urethral meatus. In females, it's about 3 to 4 centimeters long and about 1 centimeter in diameter. Closure is influenced by a number of things. So the contraction and relaxation of the urethral muscles, be it the striated and the smooth. Urethral vasculature, so when there's engorgement, it reduces the lumen size. Compliance and elasticity of the urethral walls. They generally want to be in contact with each other, and there is just a bit of tension. So there's a fluid mucosal buildup in there through the submucosal glands that kind of keeps that tension and keeps them closed until ideally you sit on the toilet and consciously say, I'm going to void my bladder now. So what causes the intrinsic sphincter deficiency? Well, as I said, age-related loss of striated urethral sphincter fibers. It's down to age, unfortunately, a lot of this one. We lose about 2% per year from our 20s onwards. So by the time you're kind of 60, 70, 80, a lot has been lost. Denervation of the pudendal nerve from stretching in childbirth and chronic constipation is another one. Lots of assessment options are there, but really they do their reliability is quite varying. In terms of what is kind of the best option for us at the moment, we would say urodynamics. So looking at the urethral closure pressure. And we know that the lower the mean urethral closure pressure is, the higher the likelihood of stress incontinence. But I don't know about the different countries. Here in Ireland, like, the availability of urodynamics is minimal, unfortunately. It was available to me here locally pre-COVID. There was a really good consultant that did it, and he had a nurse doing it, and then that service shut down during COVID, and then of course the money has been distributed elsewhere and it hasn't got back up and running again. So we just kind of have to rely on what the person tells us and kind of utilize all the tools in our toolkit in terms of treatment, rather than going, oh, I think you have intrinsic sphincter deficiency, we need you to have urodynamics before we can treat this. We just have to get on with it. That's just the way it is. If we can get it, great, but if we can't, it's not the end of the world. So in daily practice, we just kind of look at what the person tells us. So there's a link between intrinsic sphincter deficiency and post-void dribble, as the sphincter is meant to close after each void. So that's one that is a really big kind of ding, 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 I suppose, when the person tells you that. Coital incontinence as well is a big one. So when the penis is in the vagina, it should act as a backstop, therefore ruling out urethral hypermobility. So previous surgery near the area, advanced age due to decreased muscle mass, if they had an instrumental delivery at birth due to the increased risk of the denervation of the pudendal nerve, or if there was a traumatic catheter displacement. So we know when the catheter goes in, the balloon is inflated, and that's fine, it keeps it in place. We do then want the balloon to be deflated fully before it's taken out so that there's no damage to the urethra from the balloon. Or likewise, there are certain people that have had the catheter put in and it's not fully up into the bladder appropriately, and the balloon has then been inflated actually while the catheter end is in the urethra. Excuse me. And that causes traumatic catheter issues as well. So what about the pelvic floor? That's what we all want to know about, because you know, the opinion is your stress incontinence is cured with doing some Kegels, right? Maybe not. So the pelvic floor has 5 functions. It has a sphincteric function. It's a sump pump. It works to get your fluid from your legs back up into the trunk for the movement of blood and lymph and everything around your system. There's a stability function with your back and your abdominal muscles and your diaphragm to create your core canister. It provides support in that it's basically the hammock or the trampoline that keeps all our pelvic organs up in place. And it also has a sexual function as well in terms of orgasmic function. When we look at the pelvic floor, it is this tiny, very complex, very detailed, very small bunch of muscles that have a humongous job to do to keep the body functioning appropriately. And you can see a huge number of things sit on top of it. If we look at it more through the cross section, it goes from your pubic bone here, around the urethra, the vagina goes up either side of it, then the rectum comes down on the anus, and it attaches onto our sacrum or onto our coccyx. It's a really delicate bunch of muscles that need to be trained appropriately. And then if we add the likes of childbirth in on top of that, that puts significant pressure on our pelvic floor, even just to carry the weight of a baby alone. You know, people who have had a C-section are not you know, protecting their pelvic floor per se, because we know that 2 or more C-sections is the equivalent damage to your pelvic floor as 1 vaginal childbirth. So, you know, it's not to be discounted if the person has had a C-section. So how does a squeeze help with continence? So again, if we go back to these earlier seminal papers, back in 2001, our friend John Delancey, again, he's an incredible researcher and an incredible speaker if you ever get the chance to listen to him, and Ashton Miller looked at this very question. So they said, for continence to be achieved, the urethral support system needs the levator ani muscles to contract. So the pelvic floor needs to contract. This contracted, bulked up muscle supports the urethra through tensioning the suburethral fascia above it. So when it bulks up, it puts more tension on the fascia, and then that's your backstop. And it enhances urethral compression as the pressure transmits through the anterior urethral wall. During a cough, the pelvic floor contracts simultaneously, and this is where hypertonic people get caught out. So if you have a pelvic floor that's already up to high dose, it's already tight, it doesn't know how to let go, these are the people who will have incontinence, despite the fact that they have quite a strong, in inverted commas, pelvic floor. So often when we see those people and we work on down training their pelvic floor, we have to give them a full disclosure that their leakage potentially will get worse until we get to a point where the pelvic floor has kind of unwound and unraveled itself, and then we actually train it for true strength. So what is the aim of our physio treatment? Well, if urethral hypermobility is the issue, how are we doing for time? Okay, we're doing good. Treatment requires pelvic floor contractions to elevate and stabilize the bladder, neck, and urethra through tensioning and upward lift of the fascia. So yes, we're strength training the pelvic floor, but we're also trying to get bulk into it to really get that fascia tightening. However, people with a strong pelvic floor but with damaged fascia won't benefit from doing the squeezes, as the urethra rotates due to the lack of a backstop. So you can have the best pelvic floor in the world and you can still have leakage, and that's really quite frustrating for people when they come in, because the perception is that if I have leakage, I have a weak pelvic floor. But research shows that if the fascial attachment is intact, then a pelvic floor squeeze appears to stabilize the bladder, neck, and during increases in intra-abdominal pressure through an earlier compressive action on the urethra. So in an ideal world, we want the fascia to be intact and we want the pelvic floor to be nice and strong. If the fascia is intact, you can work on getting the pelvic floor good and strong and kind of aim to alleviate the problem. But if you have a damaged fascia, you can have the best pelvic floor in the world and it's still going to be problematic for that person. So the fascia is key, and that's where a really thorough pelvic examination comes into play. So how to assess bladder, neck, or pelvic floor squeeze or muscle activity? Ideally, it's with a suitably trained pelvic floor physio. We don't want, say, a baby physio who's new grad, just being thrown into a pelvic health rotation and trying to figure out how to do a vaginal examination. That's actually really quite distressing for both the physio and the patient. So we do want someone who's experienced in pelvic floor and vaginal examination. We want to do an assessment looking for upward and forward movement of the levator plate digitally. The other thing we look at is if the person isn't keen on doing a vaginal examination for whatever reason, we can look at transperineal ultrasound. So that's where we place the head of the ultrasound on the perineum and we orientate ourselves through the pubic bone, and we can see what's happening when we ask the patient to do a pelvic floor contraction or ask them to do a cough. We see the movement. It's actually what the video we looked at, that was transperineal ultrasound. Another thing that we can look at is a pelvic floor educator, and that's the device here in this kind of cartoon image, and you can see the device is inside vaginally. There's a little stick on it, and when the pelvic floor is contracted, so the device is in, we want the probe to move up and in, and then the stick will move down in tandem with that. And then when the pelvic floor releases, the probe will move down and the stick will move up. So it's actually a little bit counterintuitive for the patients because they expect when they contract their pelvic floor that the stick should lift. So it's really important that we explain to them what we want to see. It's great for people as a training tool as well at home. Often we get patients, they say, I'm really good, I really feel my pelvic floor and I feel my squeeze and I know what I'm doing, when your finger is there and I have something to squeeze around. So that's where the pelvic floor educators are really, really useful. Unfortunately, the ones that we would usually use, the knee educators, are really difficult to get. I don't know if they've stopped making them, but I was at ICS in Madrid last year and there's a really beautiful new product coming from a Portuguese physio. It's Peridel is the brand, and she's making her own version of it with inbuilt vaginal weights. So it's a really nice device. So hopefully that'll be available soon for a lot of people. And also, of course, the maple is really useful to see what's going on with the pelvic floor. Is it going to tell me about bladder neck lift and things like that? No, but it will give me an idea of the activity of what's going on in the surrounding areas. Is it going to tell me about definitively if there's a fascial defect? No, but again, it gives just a really beautiful imagery, and you can clinically reason out then from what you see on your maple report and what the patient is telling you. The biggest thing that we really need is the squeeze to be effective during a cough. So, it's all good and well having a really good pelvic floor when you're not coughing or when there's no big increase in intra-abdominal pressure. We do want it to be good enough that it'll squeeze and it'll stay squeezed and it'll stop leakage throughout a cough or a sneeze or an impact. So that's kind of really key to test as well. So it's not just can you squeeze and let go against my finger, but you want them to do a cough while you're in the vagina digitally to see what happens. Do they lose their squeeze? Are they able to maintain it? Okay, time is flying by. So with our pelvic floor muscle training, what are we trying to achieve? We need to think of our pelvic floor like any other part of the body. It's not enough to just be like, oh, I want you to do 3 sets of 10 fast ones and hold for 20 seconds. We really want to try and target it to its actual function based on what the patient is presenting with. Excuse me. So if we're looking for strength, like any other muscle in the body, we're looking for a max contraction and we're aiming for fatigue. We want to do 2 to 3 sets of 8 to 12 reps, 1 to 2 minutes rest in between, and we want to do that 2 to 3 times per week and progress up to about 4 to 5 times per week. Of course, it needs to be individualized to what the patient on the bed can do, but this is kind of a general guideline. If we're looking for more endurance, think again, endurance, like look at the difference between a 100-meter sprinter, the physique of that person versus a marathon runner. Their physiques are very different. So with endurance, it's more of a light to moderate load, 40 to 60% of a max squeeze. You want high reps, so greater than 15, a short rest of less than 90 seconds, and do it every other day. If it's more of a coordination thing, so like getting the knack and the neuroplasticity of that, we don't need to achieve max. We no need to achieve fatigue, but we do need multiple sets per day. We want that message to get hammered home into the brain, really achieve new neural pathways and get that neuroplasticity going to get the knack back in. It's something that we automatically have, and then we lose it for whatever reason, whether it be through childbirth or chronic constipation or, surgery or an incident to that area. So it's something that we can try to relearn. The treatment of intrinsic sphincter deficiency specifically, the research in 2015 said pelvic floor muscle training with alternating cues is quite important. So we want the anterior cue to get the bulbo working. The anterior cue, the newest one that has come out in the literature, is that think like, rather than stopping a wee, can you think like you are nodding or winking your clitoris? That works much better to get that interior bulbo working. The posterior cue then is to get the levator lift, that big sling of muscles at the back, and that's more, can you think like you're stopping passing gas? And that builds on sphincter bulk rather than strength. There's also injectable bulking agents. Bulkamid is kind of the main one, and it's like you are going in with I don't know if you ever put hair mousse out on your hand. When you squeeze it, it starts off small and then it expands and gets much bigger. That's what that is, and you go in and you inject it. You can see it here either side. It injects into the sphincter, and it works just as a bulk to close everything off. Vaginal estrogen is a huge benefit to people as well. It's very important that you have a GP that's on board with giving it, because some of them here anyways are quite reluctant to give it to certain people, and I'm not really sure why. But the job of vaginal estrogen is to replenish the estrogen in the sphincters, and there's a lot of estrogen receptors in sphincters. So when that's depleted, everything just gets a bit thinner and floppier and looser. When we replenish that and it bulks everything up and makes it more pillowy and full, it closes everything off much better. Likewise, if the person is experiencing fecal incontinence, it works really well at the external sphincters as well, the anal sphincters as well. So getting that on board, explaining to your patient that it's like a bulking dose for about 2 weeks initially. So it's usually every day for 2 weeks and then twice weekly after that, depending on the patient. Some people need it 3 times a week, some people need it more. And it also has the added benefits of adding lubrication and comfort to the vaginal tissues as well if they're experiencing dryness, dyspareunia, things like that. And of course, surgery is also an option, putting in an artificial sphincter. So pelvic floor training, this is kind of our bread and butter. We look at training and biofeedback options. And for me, this is where the Maple device has been a real game changer for me. Clinically, I suppose it's really challenged my clinical reasoning. And it's been really beneficial for my patients in that they love the diagnostics. They love that they can see a clear picture and I can explain to them what's going on. I love the specificity then of the treatment that I can use it for. You know, I'm not going to be driving something that's already overactive into more overactivity. I can switch that part off and I can just bring the parts up that need that extra little bit of training. I can usually see as well, you know, if there's a deficit because somebody has had an episiotomy in a certain quadrant, you know, you can work on really getting some more sensation in there. And another side of it is then the overactive people who are still experiencing leakage. We have the down training part of the treatment, and that has been really useful. Oh my God, I'm sorry, excuse me. Also, the fact that it is an MRI validated device really just gives me more confidence in the device that I'm using, and that it's really specific to the musculature that I want to work on. So let me just show you. This is just an example of a patient that I had, and we used the Maple device with her. She had tried everything. She had done everything. She was on the verge of looking at surgery. She's a nurse. Her biggest thing was when the emergency alarm bell would ring at work, she said her heart would sink because she would have to run to the patient, and she knew her scrubs would be wet, significantly wet, by the time she got to the patient. And she said, then I might have to jump up on the bed and start CPR. And it was just a very embarrassing situation for her. She had significant stress incontinence. She had one child. She'd had an episiotomy, but not the most traumatic delivery in the world. And this was her initial presentation the first day we did our assessment. So you're going to see 3 circles. The first one is her resting. The second circle is going to be the average of her 10 quick squeezes. And then the third one is the average of her 3 30-second holds. Ideally, with the first one, we want it to be as pale as possible because it's resting. We don't want much muscle activity. And then we want the second and third ones to be as dark or as grey as possible to show that there is muscle activity. Just to orientate yourself as well, let me just show you the probe. So I'm just going to stop sharing just for a second. So this is the probe. Think of orientation. This goes in vaginally. So the top ring is ring 1. That's your deepest part of the pelvic floor. And then out here is the more the sphincter. So it's the most external part of the pelvic floor. So it's ring 1, 2, 3, 4, 5, 6. We know for continence, if we work on rings 5 and 6 particularly, you will definitely get better continence. So I will show you how we got on. So resting tone, not too bad. You can see it changing there for her contractions of her quick ones, not very much darkness. And then we're moving over to her endurance. You can see there's not very much change with her contractions there. Her pelvic floor really wasn't doing very much. There wasn't much oomph in it. And then I'll just show you what the graph shows us as well. So the first part you can see there before I start playing, you can see her resting tone is not too bad. We want it to be down quite low, less than 4. Then that's her 10 quick squeezes. So ideally we want to be getting that up to at least over 16. And then this is the average of her 3 fast squeezes, 3 endurance holds, sorry. So if I go back and play that again, just to show you this part, we want this to be up here. We want that to get as high as possible. It doesn't have to be perfect. You obviously go with the patient's symptoms and how much they're improving, but that's what we want to be seeing. So that was her initial assessment. Then after a number of sessions, this was our review. So this was probably 8 sessions in, and let me just play it. And you can see the difference. So you can see there's a lot more activity on her fast squeezes, and we've got a real definite ring 5 and 6 improvement. And then again, on her endurance, you can see rings 5 and 6 are working much better, and significant improvements in her leakage as well as what she reported. She was much happier. She was able to go and do what we call a fit and jump class here. So it's half like a trampoline kind of cardio class and then a core class on the mat. And she was able to do that without wearing a pad or running to the toilet all the time. And she was delighted. She was also very concerned that she wanted to fall pregnant again and have another baby. And she was afraid of what her pelvic floor would be like. And then you can see much higher peaks now on her squeezes and much higher on her endurance as well. So she was delighted with life. So for me, Maple definitely is a really useful kit to have in the clinic's toolbox. Okay, the other thing that I utilize quite a bit in the clinic is real-time ultrasound. So whether it be transabdominally or transperineal, if you're doing a transperineal with the patient, if there's more than a 2 centimeter descent of the bladder neck on Valsalva, then we would say that there is bladder neck instability. But just from, I'll just show you a little video here, just from a training perspective and a visual so that they can see that their pelvic floor is lifting, it's really useful to use in clinic. And this is not going to play for me. Oh, here we go. So you can see the lift of the pelvic floor, it's lifting and releasing. And that was actually my little girl as my demo patient. She was probably about 7 when I took that video. So it's really good for if you're treating children as well. You can see she has a nice volume in her bladder. You could see the pelvic floor lifting and releasing. She actually needs a poo. You can see that there. But for treating children, it's a real game changer. Go again. Other things that we use, so we use like vaginal weights, we use changing their position from lying to sitting to standing. We can put pressure biofeedback devices in. There's certain ones that you can just sit on if they want to do their pelvic floor while they're fully clothed. There's ones that they can put in a probe vaginally and they play a game. So it's like you're trying to get a basketball into a hoop or you're trying to catch a butterfly with a net. There's all these interactive things. But there's also just their pelvic training, you know, trying to do their squeezes on their own. But I think in the world that we live in now, an awful lot of people want that interactivity, and it's very hard to maintain people's concentration and motivation with things. So it's really important to have a whole number of things up your sleeve that can be given as options to your patient. Now, what happens though if you have a patient and they have tried everything, they've done everything, and things just aren't working out for them? So if you have a patient in any of this kind of category, you will be kind of thinking it's time to move you on to see a consultant. If the patient has severe stress incontinence, okay, for 10 minutes. Okay, if they have stress incontinence, so greater than 10 grams leakage on a 1-hour pad test, if they leak with the first cough, so people might say, you know, I'm fine with the first few coughs, but it's only then that I start to leak. You know, fatigue is setting in at that point. But if it's a leak with the first cough, then that's quite significant. If there's 2 or more, greater than 2 episodes of stress incontinence per day, if they already have a really good pelvic floor function, if it's like grade 3, 4, 5 on the modified Oxford score, and I know there's a little bit of change in the terminology coming there as well. Instead of using the score, they're trying to kind of change it maybe to absent, weak, moderate, and strong. You know, whatever it is that you use, you kind of know what I mean by 3, 4, 5. Because if your pelvic floor is already pretty good, that's telling me that there's probably some fascial issues going on, and that's beyond something that we can change in physiotherapy. If there's been fascial damage, you know, that's probably more of a surgical thing. If there's demonstrated urethral hypermobility, if they have a high BMI or if they failed previous incontinence surgery. So people maybe have had the sling put in and they've done really well for a period of time, but that started to fail now. Then we need to look at getting them involved with a consultant. Pregnancy, weight and age are regarded as the three biggest factors influencing stress incontinence, really. But what else can pelvic physiotherapy do if pelvic floor muscle training isn't enough? You know, we're just because they haven't done super well with pelvic floor muscle training, that's not the only tools in our toolbox. So we can look at support devices, and I basically describe them as like a sports bra for your bladder. There's a whole plethora of them available. I like to get my patient to do a tampon test for me first. So I get them to drink a Baraka or something with like lots of B vitamins in it, because that will make their urine bright yellow. Then tell them pop a panty liner on and then go and do an activity that's going to provoke a leak. So get them to jump up and down, do star jumps, go on the trampoline, whatever it is, and then see how much yellow is on the panty liner when they come back in. And then pop a tampon in, a big supersized one, because we do need to fill the space, and do the same thing. Put a clean panty liner on and see, is there less yellow or even no yellow on the panty liner? And that will tell us that the tampon has actually acted as a bit of a backstop. No more than we were saying with coital incontinence, the penis in the vagina acts like a backstop. If that works, then we can explore any of these devices. So the one here that looks a bit like a cone is a Contiform. The one down at the bottom is an Ephemia. This is a Contrail Active Guard. The one that has like a stick, it looks like you're putting in a tampon. This is a Biberon Divine. This is a Uresta. This is a Poise. It's basically like a tampon. There's a whole plethora of them. Some people like them, some people don't. Some of them are one use only and some of them are disposable. But it's a really good thing to be able to offer your patient as another thing to kind of get them going with their activities, because a lot of people would just put these in when they do their sport and then take them out again when they don't need them inside. So it's a really useful thing to be able to explore with your patient. Also, some of us physios fit pessaries. There's pessaries for prolapse, and then there's incontinence pessaries. They work really well when the main complaint is sport. If the person has failed conservative management with pelvic floor muscle training, it's a really good idea to explore this, particularly if the patient isn't keen on surgery. Women predominantly bothered by pelvic organ prolapse, but a standard pessary makes the stress incontinence worse. This is where the incontinence pessaries come in, because a person with a prolapse will just have a ring put in or a dish, and there'll be no knob on it. So you can see there's an extra little bit of a knob on these. The knob is the bit that defines making it an incontinence pessary, and that again works as a backstop. You can see it in situ there in the picture. It works like a plug and it works wonders. Exercises where the knack is not possible as well, like the running, this is where it just keeps that constant pressure on the urethra and keeping the bladder up in place as well for the patient. They're really, really good. Typically physios just generally work with people who have prolapse, like kind of stage 1 and 2. If it's more 3, 4, then we refer that on to our gynae colleagues, and you do have to have advanced training to fit pessaries here in Ireland and the UK anyways. Surgery, of course, is an option as well. You can see here, this is taken from Dr. Patrick Campbell. He is a Urogynae in Northern Ireland, and he has this picture on his Instagram, and it just shows where he has taken native tissue from the person's ITV, I believe, or else the lower abdominal area. And he uses that as a native tissue sling, because we now know the mesh surgery is not available for the majority of people the world over. Despite the fact that in theory, the theory of the surgery was very good, but obviously people had some very horrific experiences with it, and we don't want that to happen to people. Many options for surgery are available, but a lot of it does depend on the experience of the surgeon and the degree and location of the repair required as well. So I often counsel my patients as well to say, look, just because Mary down the road had this repair for her incontinence doesn't mean that you're going to have the same surgery or the same outcome. On paper, you both think you're having the same surgery, but what's going on internally can be quite different for different people. So making sure that their expectations are managed, I think, is one of the hardest things we can do as physios. What else can we do? We can look at their fluid management. There's a whole heap of things here. I'm just going to go through them quickly because time is not on my side. We want them to drink appropriate amounts. We don't want them to be drinking too little, but likewise, we don't want them to be drinking too much. This is taken from the HSC website, so the Health Service Executive here in Ireland, so our governing health system. There's certain amounts for children, and then kind of once you're for over 18, they're saying about 1400 to 2.5 mils for a female, over 2 litres up to 3 litres for a male. We want them to avoid bladder irritants, so things like caffeine, citrus fruits, juices, fizzy drinks, raw tomatoes, and alcohol. And we also need them to ensure that they have appropriate fibre, fruit and veg to balance protein intake. So there's a real push at the moment for people to be having more protein in their diet, keeps them fuller, helps them metabolize things better, they lose weight, but you must be putting the fibre with that, otherwise constipation becomes a problem. Excuse me. We want them to really look at their bladder habits as well, and have they got normal bladder habits? I find that nurses and teachers would say that they don't go to the toilet that often. They're drinking normal amounts, but they're able to hold on for a long time. And then they wonder why they have stress incontinence. Oh my goodness, excuse me. So if you have somebody who is drinking normal volumes but holding on to huge amounts of urine in their bladder, there's a capacity issue. So of course then if you have a cough or a sneeze on top of that, your bladder is put at significant strain, and there's a lot of intra-abdominal pressure pushing on the bladder, and they are genuinely more likely to have stress incontinence. So looking at, are they going to the toilet enough, or are they going too much? There should be no straining or forcing the urine out. There should be no hovering over the toilet, because we know the pelvic floor doesn't relax properly if they're hovering. They should respond to their urge appropriately, not keep deferring and deferring, deferring. We try to avoid just in case wheeze if we can. That is just looking at the bladder volume, how we would measure it on the ultrasound. So again, that was my little girl. I was just taking a quick measure. So there is a formula for children, but for bladder volume, we want it to be about 400 to 600 mils for adults. Constipation then, I find this is a real trigger factor for so many pelvic issues. Now, the definition of constipation or normal bowel movements is as often as 3 per day to as little as 3 per week. Ideally, I don't like patients to be as little as 3 per week. An everyday poo would make me really happy. There should be absolutely no straining. Bleeding is a red flag. It should be finished in about 5 minutes maximum. There should be no need to sit on the toilet for a good 20 minutes. Aim for a type 4 on the Bristol stool chart, and we do know that females especially are prone to constipation, and some medication can trigger that as well. So, you know, pain relief and antiemetics. So like if the lady is particularly morning sick within her pregnancy, antiemetics are then given to control that, but then that can make the constipation side of things really bad. So looking at the medications that they're on as well. Encouraging them to do the moo poo. So I'm sure you all know how to get a person to sit correctly on the toilet. You know, getting them to use a footstool. We want their forearms to be resting on their knees, relax the tummy. And if they do feel that they have a rectocele or like a pelvic organ prolapse at the back wall of the vagina, they can use devices like the FEMIs to help support the back wall of the vagina and redirect the stool out into the correct avenue. Make a moo sound and do not strain. There's also wearables as well. So, you know, not every person wants to wear a pad, and I totally get that. You want to have your life as normal as possible, and it's really important that we try to keep people's life as normal as possible so that they do continue to go outside, do their activities, be involved in all the life events that are going on. So having nice underwear and nice running shorts and nice support garments that don't look like they're a medical device is really key. So say for the girls who are leaking urine, maybe doing their activities and then they're in a communal changing room situation, they want to have underwear that looks like underwear. They don't want to be seen to be wearing a pad. The same with like the running shorts, like with the built-in incontinence liner into it that can be just thrown in the wash. Letting your patient know that all these things are available is really, really key for them to be able to continue on the activities that they want to do. Because we don't want them to stop their activities. Yes, we want the stress incontinence to get under control, but we still want them to stay fit and healthy and active. So I'm very reluctant to tell somebody to stop doing their activity because of the stress incontinence. Let's figure out a way to manage it for the moment until we can get it improved. Exercise prescription as well. This is the bread and butter of pelvic health physios. We want them to work with a pelvic health physio, though, that is correctly trained, and also a trainer who knows what they are doing. Oh, there we go. Right, 2 more minutes and we're done. We want them to be with a trainer who knows what they're doing, because in the general personal trainer, gym instructor courses that are available to most people the world over, there's no talk of pelvic health, there's no talk of prolapse or incontinence, childbirth, pelvic floor, anything like that. It's only the ones that have really gone down the rabbit hole and gone niche into this. They're the ones that I really want my people to be working with when they go to the gym. We want them to start small and work up. Don't just ignore the problem. Change the type of exercise, maybe change the impact or the weight or the position, play around with what they're doing. Don't just grin and bear it and keep going. We want them to kind of work right up to the point of no return and get them strong there, and then progress them on another little bit. We work on the core and the pelvic floor and appropriate load transfer and intra-abdominal pressure transmission. Even like, say, younger people today, they're so caught up in like pulling in their tummy and like having a flat tummy, and it's all about the core and the six pack, and they're wearing really tight compressive leggings. That is like you have got a balloon and you've just squeezed around the middle of it. That puts pressure down onto the pelvic floor. So we really want to work on the load transfer. Is a really big thing for these people, especially the early days ones that haven't even had children yet, and work up to the point of just before the point of failure and progress on. These are the return to running postnatal guidelines. It's just a nice summary. They were designed by a physio here in Ireland, Gráinne Donnelly. She's an exceptional researcher. Tom Goom, who's known as the running physio, and Emma Brockwell. She's also an exceptional physio in the UK. You can download these for free, and they're really useful to read. They're for people postnatal, but I actually like to use them for everyone. They're a really nice structured plan for returning to exercise. So they've been printed in the sports medicine journals. They're really, really well received. Just screening stuff as well, that you want to see what your patient can do prior to getting back to their activity, if it is genuinely a return to running or a return to activity postnatal person you're looking at. And then these are just the guidelines that we have in Ireland. So you want to work within what is the standard guidelines for your particular country. And that is it. Any questions? There are my contact details. I'm more than happy to take questions, or if there's anything you would like to know about.